Okay, you guys, what a great crowd. Thanks so much for coming. On behalf of Captain Scott Goldstein and the Pikesville Volunteer Fire Company, I welcome you to our new space, training space. We very much appreciate you coming. We more than that appreciate the work that you guys do for the community. So thank you for that. The Medical Director's Office for Baltimore County, Dr. Pollock, wants to support the EMS. I'm Sean Bernold. I'm an anesthesiologist at Critical Care Physician at Johns Hopkins and a member here at Pikesville. We've been working with the Medical Director's Office, with Dr. Jeff Sagel and Dr. Vitberg, to put together a robust EMS lecture series for you guys. I think this is probably our 5th talk. We have speakers now booked through the end of January. Twice a month on Monday nights. We recognize we'll be passing around a sign-up sheet also. MIEMSS did approve us for CEUs, which is great news. We're also going to make a video recording of this talk, and we hope to make this available to you guys in your company. So if you wanted to view the training on another night, that would be great also. If you want to get CEUs off of viewing that video training, I think we're going to be able to make that happen. I'm still waiting for a final okay. If that's true, then just do a sign-in sheet. Make sure you include your MIEMSS number as well as your name. If you send that to us, to me in particular, I'll submit that to MIEMSS for CEUs for other nights as well. So if you guys have any other suggestions with speakers or how to make this better serve your needs, please let us know. And again, so much thank you for coming and taking the time out of your day to be here with us. Super spectacular. Sir?
Just a quick question. Do you have the schedule published?
So we have been publishing the schedule. Well, I don't know what published means, but I've been sending it. It's been posted on the Volunteer Association website. Judy Douglas has been sending that out every week, I'm pretty sure. I've seen that come around. For the career department, I think we sent it through
Rich Shenning in the Academy.
To be submitted out via the Fire Rescue Academy. If you guys have other suggestions on how to get this stuff out there, please let me know. So thanks so much. Dr. Dave Vitberg is talking tonight on Rescue Box Medical Ops, optimizing patient care during complex rescue and extrication. Most of you probably know Dr. Vitberg. I know he's the Director of Critical Care at CBOC, Associate Medical Director for the Baltimore County Fire Department, among many other roles and hats. Dave, thanks so much for sharing your expertise.
Sure.
And Josh also. Thank you.
Come
so
on
much.
down.
Can
I leave this, since it's the two of us, can I leave this in the center and pray that it will pick us up?
I would prefer not.
Prefer not. Okay. So we'll figure it out. All right. So thank you very much for coming tonight. I just wanted to say thank you to Sean and Jeff Sagel and all you guys for, I feel like the weatherman. I feel like I need to talk about relative humidity. I just want to thank them for organizing this. I said this at the last talk that I was at a few Monday nights ago when Dr. Sikorsky was here, but I think that we're entering a new phase of excellence in Baltimore County, and largely in part to the efforts of Jeff and Sean putting these lecture series together. We want to do more dedicated training, specifically more EMS training, and try to even the weight between EMS and fire training. And while this is important, the classroom stuff is important, we also want to do a lot more didactic, hands-on simulation training. So this is all part of the equation, and I just wanted to say thank you. I'm very thankful and honored to have Sergeant Josh Hines with me from the Maryland State Police tonight. This is going to kind of be a collaborative back and forth, and we both prepared this talk for you. We're going to be talking about optimizing patient care during extrication and complex rescue. I don't want this to be a one-sided talk. There are a lot of people in here that have taught me a lot of things, and I would love for all of you that have been in the game for a long time, that have been doing this, that have strong feelings about the way things should go, to speak up. And yes, there are a few of you in the room tonight that might have something to say. So one little caveat is that this is not a vehicle and machinery exercise. If you want that, MIFRE is down the block. You can go take that. This is actually a scene from the extended 3-hour patient extrication that Josh and I both responded to on Friday out on Black Rock Road at Falls Road in a 49 box. Was anybody Anybody in the room there? Yes, I remember you. Okay, good. Excellent. So we'll talk a little bit about this call because it was particularly challenging. I actually rank it in kind of the top 10 most challenging calls that I've been a part of and extrication efforts that I've observed. And it presented a lot of challenges with regard to taking care of the patient. So our focus tonight is going to be on teaching you and talking to you about high quality and, if possible, if evidence exists, evidence-based patient care during complex rescues. What does the evidence tell us about how to take care of these patients? Anybody recognize the picture on the right? Anybody from Reisterstown, or anybody remember being on? Where was this?
Full moon.
That's right, the Full Moon Saloon, aka the Death Trap. So that stretch of road, bad area. This was a guy who drove his vehicle right underneath the roll-off dumpster, and his head came to rest about 2 millimeters in front of the end of the roll-off. And I think all the folks that were on that call received, you probably have a nice framed certificate if you were there, a unit citation, and I thought it was a great rescue, and it was a pretty complex rescue, and we can talk a little bit more about that in a bit. So, what type of complex rescues have we actually seen recently in Baltimore County? Well, this is a perfect example of a call that a lot of you were probably at. Anybody 32 remember this? Raise your hand if you were there. If you were,
I did have some man.
look at that. The original incident commander is here. We're honored. So this was a roof collapse out in Reisterstown. But we have motor vehicle crashes are probably what we're going to be talking about most tonight. Roof collapses, trench rescues. On the east side, we have a lot of industry, and we get limbs entangled in machines. And I was in my car squirreling around a couple weeks ago, and I listened to a rescue box where we sent, multiple pieces of apparatus, lights and sirens, for a guy stuck in the mud off of a dock on the east side of the county. That was very exciting. So we have a lot of different types of rescues. So what Josh and I are going to talk about is we're going to kind of break things down into different phases. Phase 1 being the dispatch and initial response. Phase 2 being initial assessment, kind of when you pull up, like the call we had last Friday, and there's a huge commercial vehicle on its side, and you can maybe see the patient's head. How do you do an initial assessment? Phase 3, patient care during the rescue. What should you and shouldn't you do during the rescue as far as providing care? Post-extrication care and transfer of care, particularly when it involves transfer of care to a higher level of care, which is usually the Maryland State Police. So this is what we're talking about. This was actually the scene from Friday. This was kind of looking down, many feet in the air, looking down into the cab. It was a tree trimming truck that lost it and rolled onto the passenger side. And it also went right into a tree. And does this have a little pointer? Oop, I just did something. The tree actually pushed right through the engine block, creating a massive amount of compartment intrusion, rolling the dash up onto the driver and passenger. The driver was actually killed instantly, and the passenger, who was actually in the most bottom-dependent portion of the commercial vehicle, which is a tree trimming truck that was kind of encased in a steel cage, was actually pinned between the deceased patient, the dashboard, deceased patient, and the seat, only visible from the neck down. And so it took us 2 hours to actually get out the priority 4 patient, and then it took about another hour to get out the priority 1 patient. So how do we provide optimal patient care, perform actionable assessments, and administer time-sensitive interventions in here? Or should we even bother? Should we just let rescue crews go to work and try to effect rescue and get the patient out? And then care when folks like Sergeant Hines arrive and they're ready to fly the patient downtown. So I'm going to fill this talk with a bunch of slides that are entitled Critical Decisions. So I you guys a little bit. So anytime you see a slide that says critical decision, it's going to be a question. So this was our call. This was the cab of the truck. He was the passenger occupant. It was a heavy-duty commercial vehicle, passenger side resting on the ground. Significant impact both into the ground and into the tree, which transected the engine block and compressed the compartment. We had from his pelvis downward, he was actually pinned between the seat and the dash, and then his chest, abdomen, and pelvis were pinned between a deceased patient draped across him and the back of the seat. So based on the preliminary information above that I've shared with you, what's the minimum trauma category of this patient? If you arrive on scene and dispatch is down your throat like they are every 3 seconds and you're trying to figure out what the hell's going on, what category can you determine? Right? So I heard death in the same passenger compartment, never a good thing. What minimal category?
I mean, it's entrapment mechanism, C at least.
Okay, so at least a C based on mechanism. Okay, so for those of you that don't know, a lot of times before I studied for my EMS boards, which I just took, I kind of looked at the trauma decision tree, tried to commit things to memory. But I hope you guys know there's actually a much easier way to remember things. Category A patients are Category A based on physiology. All the things in Category A are based on vital signs. GCS less than or equal to 13, so on and so forth, systolic less than 90. Category B is based on anatomy problems, C on mechanism problems. That's where somebody yelled out death of same passenger compartment. And Category D is a lot of other stuff. Is it an elderly patient, which we notoriously under triage and don't take to trauma centers? Is it a child? Are they on anticoagulants like Xarelto or warfarin? Are they pregnant? And then they always reserve EMS provider judgment so that you can always have an out if you think your patient would be best served by going to a trauma center. So I didn't tell you anything in this little vignette about his vital signs. So while you might assume he's a Cat Alpha, based on what I told you, he likely has some chest wall instability with that deceased patient across him. He likely has a crushed extremity. He likely has some pelvic fractures, all of which he actually did. So he's at minimum a Category B, bravo. So what organization, this is a trivia question, what organization creates and disseminates the guidelines for field triage or injured patients, the trauma decision tree that we have in our protocols? Who came up with that? What's that? ACEP in conjunction with what was the organization above ACEP that brought together this collaborative group? Anybody know? So it's actually the CDC, which is part of DHHS. The Centers for Disease Control actually published the initial and all of the updates for the trauma field decision tree that we use day in and day out in Baltimore County and in Maryland. Last question before we go on. Compartment intrusion and deformation are equivalent considerations during rescue. So intrusion and deformation, equivalent when you kind of look at mechanism of injury, assessing a patient. You're shaking your head no, and why?
Yeah, formation of the car, or maybe crumple.
Precisely. Right. So intrusion, you actually have to push things into the patient compartment where the folks are sitting. Who knows the measurements that predict bad outcomes or severe injury for where a patient is seated versus elsewhere in the vehicle? What are the measurements? 12 inches where your patient's seated, or 18 anywhere else in the vehicle, including in the latest 2011 update of these trauma guidelines, including the roof, which was actually not in prior guidelines. So 12 inches where a person's sitting, 18 inches elsewhere. If you come to a scene and pull out your ruler, I'll be proud of you. I don't know anybody that does that. It's usually just more of a gestalt looking at everything. Deformation, cars are designed to crumple. There is often going to be much more than 12 to 18 inches of deformation. Deformation and intrusion are not synonymous. So now we're going to talk about dispatch and response. Josh, you want to tell us a little bit about, as you're responding to a call, what you're thinking about?
So a lot of times when we get these calls for go team requests, what we try to do is find out, are aircraft needed at the scene first? Is this something where we're just calling because it's a lengthy extrication? And more often...
Try this already. Yeah.
Is that better? So more often when we get calls for these lengthy extrications, these entrapments, what we try to do is coordinate with SysCom, the ground providers on the scene, to see if the go team is going to be requested. Because it's one of these things where we can be more efficient by stopping by the trauma center and picking up the trauma docs and the anesthesiologist or the CRNAs, and then making our way to the scene, instead of us flying to the scene, getting halfway there to find out, hey, can you go back and get the doc? So you got to figure the way our aircraft are set out around the state, Trooper 2, which is in Washington, Trooper 6 in Easton, Trooper 3 in Frederick, they're going to be the next closest aircraft. So if we're responding somewhere to a scene, now you're waiting an extended period of time to get the go team. So we try and grab that whole package if we can early on on the request. But essentially, we will, go to the scene most of the time without the go team. That's typically what happens. And when we land, we find out that they're going to be trapped for another 30 minutes or so. And then someone starts, hey, let's think about this. And that's where the need for additional resources really needs to come in early. If you need the go team, you need an aircraft, call for us early. We're happy to come pick patients up. We're happy to come pick up the go team. If you cancel us, that's fine.
So this is an actual picture from the last go team call started last Friday that we had out in Morgansville, Maryland, which is near Hagerstown. Trooper Peach, I believe, and one of the CRNAs that was with me, Kristen, and she's doing what I think, you know, if you have the luxury of time and you're not sitting in an apparatus for 2 to 3 minutes, she actually pulled out her RSI cheat sheet, was drawing up some drugs for what we thought was going to be a 14-year-old patient that wound up being a 30-year-old patient. But preparation is key. So dispatch response phase, you want to go through information gathering. Pre-planning, you know, you want to get as much incident-specific information as possible from dispatch. What's the mechanism of injury? How many patients are we treating? What are the potential hazards? Start thinking about it, especially if you're sitting in the front seat, what are the anticipated resources that you're going to need? Come up with your initial tactical / operational plan of attack. Observe during your response traffic, weather, wind, road conditions, all of which will have bearing on whether or not the troopers are flying, how safe people are going to be when they're flying into your scene. And you want to talk a little bit about what you specifically want when you're responding.
When we're en route and we're trying to come up with a game plan as well, the biggest thing we want to know is whether or not the patient's awake, if they're conscious. Especially on a lengthy extrication like we had the other day, when I walk up and they say, oh, he's sitting there talking to us. Well, that changes a lot when it comes to planning out our treatment. If we get there and find out that now he's unconscious, now we need to think about how fast can we get this guy out, because we don't want it to be a recovery. And so we really just need to know, are they alert? Are they with it mentally? If not, then we need to start planning, you know, airway, fluid resuscitation and whatnot.
So I think one of the things that I like to do, I don't like to commit anything to memory. So if I know what I'm getting into, I like to quickly look on my phone, look at some protocols. If I need to refresh my memory about things I might have to do. I think any good officer will pre-assign roles so that when you jump out of the engine, truck, whatever you're responding on, everybody's ready to go. The trigger's pulled and we're ready to act. The key thing is the clock starts ticking, and one of the things that I know is near and dear to some of the folks, especially in my first due, is sitting around on scene, particularly after we extricate a patient. You know, we're already looking at prolonged scene time whenever we start extrication or rescue operations, but then we have this tendency, particularly in Baltimore County, to kind of sit around and set up shop and do a lot of things on scene rather than start movement towards definitive care. So during dispatch response, there's some of us that like to start a little stopwatch on our watch and kind of keep track of how much time has elapsed. Is there anything else that anybody in here can recommend before we go on to the next phase, as far as sitting in the front seat, responding on a medic, on an engine, on a truck, on a rescue? Is there anything else that goes through people's mind as they're heading to a rescue box that we've overlooked? If you think of something, shout it out.
I think the biggest thing, Dave, is to make sure that people leave room for the other responding apparatus.
So this came up on Friday, and 303 was special requested, and we could have used them right up at the scene. And at the end of the day, we had to have the squad. Anybody from Lutherville here? Okay. So we actually had to have the squad go all the way around all of the obstruction that we created and come back because we thought we were going to have to use them for both winching and lifting operations. So again, while this isn't a talk on, you know, kind of the fireside rescue extrication tactics, this all goes hand in hand. You can't effect rescue and save the patient's life unless you think a little bit and think about, where's the squad coming in? How is their winch going to be positioned? If I have to special request a piece of equipment, where are they going to land? I learned this the very hard way from an officer here who's I think a battalion chief in Baltimore City. I'm not sure what his rank is. He's a chief in Baltimore City. When I first got my car and I first started responding and I went to a rescue out here in 31, and the squad 322 came, and I was between where the squad landed and the car that they needed to winch. I think they wanted to go through my windshield to hook the car up and winch it out. So positioning is everything, both in life and in your professional and personal lives. All right, so one of the things you absolutely have to know if you're going to be responding to any sort of rescue is the incident command system. This was my study notes for my boards that I just took. You have to know, as an incident commander, you know, this thing can get big very quickly, particularly when you're on a call like we were on Friday, where you start getting multiple jurisdictions coming in, special units like MDE coming in, ancillary care teams like the GO team coming in, Maryland State Police. This thing can expand very quickly. So you have to know your incident command system. You have to know that we as medical providers fall under the operations section. If you ever want to remember the sections, just remember the mnemonic FLOP, okay? Finance, logistics, operations, and planning. We rarely get into events where we have to set up shop with finance and logistics. Sometimes with planning. Most often we're just working under kind of the operations phase of this diagram. So, question, according to ICS 100, which everybody in this room I think has to take if they get on a piece of apparatus, what are the 3 essential priorities of any incident commander, be it at a complex rescue or a building collapse, a bus crash on Reisterstown Road? What are the 3 principles that have to guide an incident commander at any of these events? This is a good review if you're taking.
Life safety.
Yep.
Incident stabilization, property compensation.
And that's why you're wearing the white shirt. Perfect. All right. Anybody that is wearing a white shirt best know this, or a gray shirt. Life safety is number 1. Incident stabilization and property conservation. That is on any test you're ever going to take where incident command comes up or rescue comes up. Anybody know what this is a picture of? Yeah, Sparrows Point. There was a section of Sparrows Point that collapsed as they were taking it down. All right, so initial assessment. You want to talk a little bit about initial assessment? Kind of pulling up.
So from our side, when we first walk up and we see this, our first thought is, okay, the guy looks like he's sitting up, he's on oxygen, looks fairly stable. Some things that kind of stand out here is the things that we all need to be aware of is personal protective equipment. And that's why a lot of times we don't get in the car and involved with patient care as much, because this is my outfit, other than I have a life vest wrapped around my neck when I'm on the scene. And so I'm not in a position to jump right in while they're cutting cars and trucks up. On the other hand, we have some gloves and no helmet and maybe some eye shield, and even this gentleman here maybe having his face protected. So little things like that we want to look for. But that initial assessment, I want to look at his color, his alertness, and all those things are going to tell me whether I need to step in and do anything, or I can step back and just let you finish your job. And that's real quick all I do, because when he's talking about incident command, I'm walking up looking for someone with a white helmet. Because when we walk into your county, I might be familiar with Baltimore County because this is where I got a lot of my experience. On the other hand, when I go in other jurisdictions and it's a guy with a pair of shorts and a reflective safety vest, and that's incident command. So, we see a variety of incident command systems, and we just want to identify what's going on, what other resources do they need? Do they need us to get in and do anything right away? Or if the GO team pulls up, we're all doing the same thing. So when I walked up the other day, meet up with Dr. Vitberg, what do you got? What do you need? And at that point, the guy is just trapped by a deceased patient. And that's all they know, other than the fact that they can see him blinking and talking. And every once in a while, the firefighters would yell up from the hole, hey, he's still talking to us, he's still following commands. So right there, okay, I'm just going to stand back for the next 2 hours and hang out. And then as we progress and the patient status changes, that's when we need to start thinking about resuscitative measures.
So a couple pearls, and again, I'd love for the folks, especially in the white shirts or with those with gray hair, to speak up. I'm not as young as I look, but I'm also not as old as most of you. So phase, let's say that with peace and love, peace and love.
Your car's on fire.
All right, you help buy that car. So initial assessment, quick list. You got to ensure incident command is in place. It pains me to listen to some of these calls on roll where it takes 5-10 minutes for somebody to assume command. You got to have somebody in charge, even if there's 2 people on scene. Life safety is always a priority. This call we went on Friday was a great example of there were a lot of things there that made me nervous. There was oil leaking onto the patient's head. There was gas leaking from the truck. There was a tree that was at a 45-degree angle near where we had to access the patient. There were a lot of things that could go wrong. So you want to make sure your rescuers are safe before they start treating the patient. Assign roles and responsibilities early. Identify and activate additional resources early, be it launching a trooper. This is not a dedicated talk on the GO team, but we'll pull that plug. Whether it be a special request for a piece of apparatus in Baltimore County, like the squad from Lutherville, Sort 50 from Station 50 that has enough equipment to treat 250 patients. Think about these things early and get them on the road early. Assign a prelim trauma category, Alpha Bravo Charlie Delta. Assign a preliminary priority. I underline and italicize the word preliminary because a lot of times when we don't have great access to these patients, that changes as things evolve. What looked like a Cat Alpha initially may just be a Bravo or a Charlie down line. Initial priority 1, you get them out, you kind of brush them off, becomes a lower priority. Initial impressions, so if you ever take PHTLS, the guidance is that you form your initial impression of what's going on within 15 to 30 seconds. And in our state, that means a quick consideration of whether or not that person's going to go by ground or air. And the consideration for that and how you make that decision is born out of knowing the trauma decision tree. Alpha Bravos tend to go by air, Charlie Deltas by ground, unless you're within 30 minutes striking distance of a trauma facility. So from, I got my firefighter card, right? I got white pat tags. I've taken rescue tech. I've done all that. Just as a quick little refresher, each extrication tactic in any textbook I've ever read is should take 5 minutes. And I know that's pie in the sky. And once you get to more than 4 sequential tactics, you're talking about 20 minutes. And that's really where you start thinking that this is a prolonged operation. Unfortunately, a lot of people realize this too late after the first 4 or 5 maneuvers have been done. And they're realizing, wait, this isn't going to happen quickly. Maybe I should have called for additional resources earlier. Any textbook you read on emergency medicine, EMS, any article you pull out on optimal care during extrication talks about having an EMS provider in the car. Well, that sounds great, but it can be profoundly challenging, and I know you guys know that. At the call we were at, as we kind of were tunneling down, and by we I mean I was doing nothing, as the rescue folks were tunneling down, kind of pushing sequential rams, trying to get down to the patient, get the deceased patient off of him. There was only room kind of in the encased area for one person very late, about 2 hours into the operation. And then things kind of opened up a little bit more. And the decision went to insert a medical provider, which was me in that situation, had to be made with the people affecting rescue. And there was only one of us that could get near the patient at a time. So we had to collaboratively work and figure out who's going to go in, when was I going to go in, when was I going to put an IO in him, if and when were we going to start blood transfusion, if and when was I going to get in and get another assessment. And so all of this has to be done collaboratively. Ensure the EMS provider is wearing proper PPE. This is actually outlined very clearly in NFPA 1999. EMS providers, if they're going into vehicles to do all this stuff, they have to have close to structural firefighter gear. Simple basic questions to ask when you can actually access the patient. Is their airway open? Can they protect their airway? Are they oxygenating and ventilating adequately? Is there any obvious external bleeding? And what is the anticipated extrication time? And has a plan, have tactics been developed to get this patient out? So sometimes the best medicine is for me and Josh to actually sit back like we did for a very long time on Friday and let the folks that actually know how to effect rescue do their job. And I'm preaching to the choir if you ride at 32. But oftentimes the best thing for us to do is to sit back. As I thought about this and I put this talk together, I realized that there are many parallels between extrication and rescue operations in tactical medicine. If you think about it, in the hot zone in tactical care, the best medicine is Sean and his gun right there, a bullet, or actually, I've got 2 right here, or maybe somebody else. The best medicine is returning fire and neutralizing a threat. Much the same in the hot zone of a complex rescue, the best medicine is often Hamatro. In the warm zone, which is, I think, where we were standing that day in the middle of Black Rock Road with some oil kind of spilling past us, all the kind of chopped up tree parts on the ground next to us, and kind of in the zone, if that vehicle rolled, we would kind of be hustling out a little bit. We were in the warm zone, and in that zone, for those of you that haven't been in the game a long time, situational awareness is critical. I can't tell you how many times I've seen people on calls without reflective gear in a roadway, just a 2-lane road up here. It's a recipe for disaster. You've got to be aware of what's going on. You've got to have reflective gear on if you're out on the road. And then, the treatment priorities in tactical care are remembered by the mnemonic MARCH. You guys know what does MARCH stand for? What is the M? For airway, R is for respiration, C for circulation, H is for head trauma and hypothermia. The tactical priorities in rescue are much the same. If you get into the cab of that truck, and the patient has a complex fracture and has an exsanguinating hemorrhage, immediate tourniquet application should be the way to go. And I keep some of those in my turnout gear pocket. And after that, basic airway maneuvers. Maybe the patient just needs a nasopharyngeal airway to kind of temporize them until they can get out of wherever they're trapped. Respirations and circulation, a little more complicated with circulation. Putting in access in a patient that's trapped is a little controversial and really has to be taken situation by situation. We'll talk about that in a bit. And then prevention of hypothermia is actually critically important, but profoundly challenging as you're trying to extricate somebody. We're going to take a look. The next 6-7 slides are actually pictures from recent calls where either MSP was dispatched or the GO team was dispatched, and we'll kind of go back and forth and talk a little bit about our experience with the initial assessment.
The reason I put this slide in there is because a lot of times there's a stigma of, oh, I'm within that 30-mile or 30-minute drive time to the trauma center, so I can't call for a helicopter. I can't tell you how many times after the protocols were changed back in 2008, 2009, after the crash of Trooper 2, people were still not up on the trauma decision tree, and so they would plaster it inside the medic unit, or they felt that their medical directors were going to scrutinize every little decision that they made. And our mentality was, just like early on, if you get there and the patient's wrapped around a tree, call for us. If you extricate them, and like you said, you just got to dust them off, they're fine, everything's good, then cancel us and you can take them to the local emergency department. Not a big deal. But this right here, this was a natural resources police officer on 395, or at 95 at 395, right before the ramp. So we're literally a 20-second flight from shock trauma. And this was a GO team request, and we had 2 aircraft on the scene there. Now, this gentleman was heavily trapped, and the ideal thing was, as they were finishing the extrication, I tell the pilot, go ahead and spool up. He comes out onto a board, literally enough time for us to secure him, and within 2 minutes, 3 minutes, he's in the trauma center being completely evaluated. And that was the way the plan worked. So, you know, yes, we're in Baltimore County in Pikesville. My flight to shock trauma is probably 2 to 3 minutes. Dundalk, Catonsville, I've done RSI Airways there. I've had lengthy extrications there. And the ground providers did a great job when they walked in the door and they called for additional resources. We were on the ground waiting for them at the LZ, and the patient was in the hospital within minutes. So we can definitely help out close with even, and these guys jumped in the car and drove from the hospital. They were that close. But just food for thought. This gentleman here, everyone's pretty much familiar with the Port of Baltimore. There's a person laying between that truck bed and the tire. He was standing on the platform telling people, telling someone to back the tractor up, and he lost his footing and landed, and the guy back straight, with him laying flat, back straight under the truck bed. And so he had been laying there. He was awake, he was talking, but he was getting steadily lethargic. So what we did was we had a plan that whenever they could lift this up and slide him out, they literally slid him over to a board. As they were strapping him, his respiratory fatigue was setting in, quickly put a nasal tube in, and before I had that secure, we were rolling to the aircraft. So again, another situation where his airway was secure, we gave him fluid and all that stuff while he was compressed, but you know, once he was released from the pressure, you know, he had a bad outcome.
So one of the things that I wanted to ask you about was up here, a little bit outside of the Beltway, we often kind of scrutinize when people call you, and we have maybe a 20, 30-minute drive time to Sinai or downtown. And one of the things that I think I've heard from providers in the county is sometimes they get a bit frustrated with the time it takes after they've packaged the patient, done their interventions, to transfer them to your litter, put them on your monitor, and people kind of in their head think, okay, I got to add in that time, and then I got to add in the time to get back in the aircraft and power up. What is your expectation, and what is MSP's expectations as far as packaging a patient, handing them off, and you getting out of there?
It's a question we get a lot. The way we teach our medics is that we want to be on and off the scene within 10 minutes. And one thing that's frustrating for us is that we're requested on so many medevac scenes, and then they land us at an LZ 5-6 miles away. Well, by the time they, get the patient out, do their thing, start their IVs, do the airway, they stay on the scene at the location. And then when everything's done, hey, who's driving the medic? Right? Okay? And the next thing you know, the medic's got to drive over, so then we walk in. Well, like any turnover, whether you're at the hospital or if you're a BLS provider and you're giving the care off to an ALS provider, they're going to do an assessment. So when we walk in, we've gotten complaints before, oh, the medic never looked at me, and the whole time all he did was focus on the patient. My mentality is, hey, tell me what you got, what's going on with the patient, and while you're doing that, I'm usually putting my gloves on and I'm looking at the patient, just getting my general impression. Does he need an airway? Does he need a chest decompression? Does he need a pelvic binder? A lot of these things I'm going to be able to find out just by looking at the patient. So our goal is, while you're talking, we're doing a quick assessment. Now we're carrying a second set of hands. We have rescue technicians, another paramedic on board the aircraft. And the way we train is that myself as the crew chief, I go in at the head, I get the information, I do my airway assessment in the upper body. The rescue tech does from the pelvis down, and then they provide the information back to us. And the nice thing is, we come in as a team, they put the monitor on while we're doing that, and now our stretcher, if you remember in the old Dolphin days, we had a stretcher we had to carry to every scene. Now, we just roll right up to the side of the aircraft, stretcher's mounted, you slide right in and go. So, we try to be on and off the scene in 10, and unless there's some sort of life threat or a situation where we need to stay on the scene and manage an airway or something.
So this is another picture from a GO team call 2-3 years ago down in PG County. Anybody from PG represent? Holla. So this is a picture from PG. I have a 40-year-old sense of humor. I apologize in advance. This is from PG County. This is a bad day. This is a guy who, you never want to be this guy where somebody says, hey, why don't you go clean the mulch auger? You probably don't want to hop in and clean it and have it power up. But that's exactly what happened. He hopped in the hopper, and the mulch auger, the blade started spinning, and it train sucked in his left leg and kind of bent his right leg around his back in some sort of fancy yoga position. And, this is a good, again, talking about initial patient assessment. If you're throwing ladders and you have somebody's leg sucked into an auger, probably early activation of all these additional resources is a good idea. One of the things that I think about when I see this slide is that in Baltimore County, my personal observation is that we tend to underutilize and under-administer analgesia, fentanyl, for people that are in pain. And this guy was in a world of pain, and I think one of the benefits of getting the Maryland State Police and the GO team there was the ability to actually intubate him and put him under general anesthesia while they disassembled this thing around him. So just remember, sometimes these things are painful. This was right up here in Pikesville, off Wood Valley. This was a trench rescue. Things happen locally, and you guys have the confined space team, and you were there. So a whole different set of considerations here. I'm not an expert in confined space rescue, nor am I an expert in trench rescue, but I can tell you this was in the middle of August. It was right after I became one of the medical directors. I responded. It was 1,000 degrees outside. I soaked through all my clothing, and he came out, and guess what he had? He had profound hypothermia from being encased in kind of mud around the foundation of this house off of Wood Valley right here in Pikesville. This was another treat. So this was a call up on Shawan Road in 83. And I pulled up pretty early behind one of the first units here, and I saw this. And I thought we were going to be dealing with many different patients. This was actually a car carrier that overturned. There was one patient, and he was severely entrapped and severely priority 4. But again, very difficult to do a patient assessment until this thing is very, very stable on slick ground, mud, snow, ice. Life safety, first priority of an incident commander. We're going to finish up phase 2, then we'll take a break and get into the end of the talk. So, identifying patients with shock, who is critically ill, who needs to be rapidly extricated is a key thing that has to happen. And there has to be a very, very good conversation between whoever is in charge of the rescue operation and whoever is inside the vehicle. Have to move. Are we going to just quickly try to pull them out or effect a few cuts and get them out, or are we going to kind of slow things down and do this a little more meticulously? In the out-of-hospital setting, shock should not be measured, especially in these calls, by blood pressure. Shock should be based on signs and symptoms like what's the patient's mental status, are they tachycardic, are they tachypnic, what's their skin temperature, are they mottled, are they cold. in these events, specifically in these tight rescues, are notoriously difficult to get and notoriously inaccurate, and blood pressure tends to fall late as people are really, really crashing. So it's very hard. The other thing I would say from a practical perspective, because I like to be practical and not have talks filled with, fluffy stuff, it's actually very difficult to snake down a non-invasive blood pressure cuff attached to a monitor when a patient's trapped in the car. It's actually a good thing to practice taking a blood pressure by palp every now and then, or taking an actual real blood pressure, which will also be challenging because of all the noise. But taking a pressure by palp is probably a skill that deserves more practice, particularly in these situations. It's useful. Just a little interesting tidbit, shock index is emerging as a decent way to identify people that are in shock. It's basically your heart rate divided by your blood pressure, your systolic blood pressure. If it's greater than 1, it's associated with the presence of shock. So, for instance, if your heart rate's 100 and your systolic's 100, you have a shock index of 1. If you become more tachycardic and more hypotensive, that goes up. Anything above 1 is associated with shock. That would be a critical patient. That would be somebody I try to hustle and get out as quickly as possible. End-tidal CO2, I'm going to say one or two things and then hand it over to Josh, is nasal capnography. So we actually had this guy trapped for 3 hours on Friday. And as we gained a little bit more access to him, I crawled in. I drilled an IO into his proximal humerus. We realized that he was very much in shock. We started transfusing him blood through the IO attached to a pressure bag. And then we tried to get a blood pressure cuff on him and snake it out to a monitor. Useless. Just too much cord tension on the cord. And then we tried to hook him up to nasal capnography, which has two pieces. One goes to the O2 tank, one gets screwed into the monitor. Again, it looks long, but it's quite short. I hear that a lot. So can I say that with everything that's going on in the world today? Probably not. So when you edit this, just all right. Right. What? There's somebody else giving this talk? All right. End-tidal CO2 would have been really nice. So we put it on his face. First issue, a lot of pull. So he's down in that hole. Serial rams trying to push things out. Everything's being stretched out. The monitor's moving a little bit. The patient's moving a little bit. Didn't stay in his nose. It didn't stay seated properly. Problem 2, those microstream nasal capnography devices, if there's a little bit of sediment in the air or that gets kind of in the pathway of where it detects the end-tidal CO2, the sampling port, useless. And the nice thing would have been if we had it on his face, I think I would have seeing the monitor on the edge of the truck and just knowing that extrication could proceed, the guy's still breathing, seeing a nice waveform go up and down, but it's often not practical unless you're like the call in Reisterstown by the full moon saloon and the roof's off and you got access to one of his arms and you have access to his face. Every situation is different. Every situation warrants different tactics. In general, if somebody has a fixed ventilatory rate, if the respiratory rate is around the same and their cardiac output starts going down, the end-tidal CO2 will start going down. Because remember, the only way end-tidal CO2 is generated is by blood being circulated and coming back to the pulmonary circuit, to the lung, and being exhaled. So if somebody has a relatively constant respiratory rate and starts going into shock, you might start to see the end-tidal trailing down. And again, would have been great to put on that guy on Route 140. Not so much in the patient that was heavily entrapped on Friday, where everything's being pulled and it won't stay on his nose, and there's a lot of crap in the air. Conversely, if the cardiac output stays the same, but the patient has chest injuries and starts hyperventilating, CO2 will also go down. So I was talking about this particular call with Josh before we came here tonight, and putting nasal capnography on the guy would have been a good thing just so we could have a better remote assessment of his ventilatory status as people were trying to cut him out. But a declining CO2 could have meant a lot of things. It could have meant his chest was continuing to be compressed by the deceased patient across it, and he was just becoming more tachypnic. It could have meant that he was slipping into shock and he was exsanguinating into his multiple pelvic fractures and his femur fracture. So looking at the number in isolation, generally useless. If you put it on somebody's nose, it's generally good to just make sure there's a waveform and that patient's breathing. You're really looking more for an absolute and not for a quantitative number. If you put that on and you step back and you can position that monitor such that you can see it and let people continue to try to effect rescue, and you see that waveform going up and down, you know chest rise and fall is happening, you know ventilation is happening. As far as the actual number, not a whole lot of useful information there. Anything to add on capnography?
I was just going to say that a lot of times with capnography, we can go in and assess someone who's got a decreased LRC, and once we apply it, we can see, okay, their ventilations are fine, or they're obstructing, or they're tachypnic. It gives us a little bit more to go off of than just, okay, I've got chest rise. And when you've got a patient that's difficult to access, it's kind of nice if we could have put that on his nose, and we could see, okay, is this CO2 in the low 20s? Why is that? Is he hypovolemic? Is he breathing 45 times a minute? So all those types of things are going to also dictate our course of action when it comes to patient care. So we love end-tidal. We put on end-tidal on just about everyone in the aircraft.
And just as a reminder, in Baltimore County, it is 1,000% essential to have inline capnography for every intubated patient. We've been reluctant to fully release nasal capnography in the field because there is 0.0 proven benefit that it improves outcomes in the pre-hospital environment. Typically in the hospital, nasal capnography, and I'm nervous talking about this in front of an anesthesiologist from Hopkins, but nasal capnography, the most beneficial place for nasal capnography in the hospital setting is for people that are receiving procedural sedation. They're getting a colonoscopy, as some Versed said, and you may be potentially suppressing their ventilatory effort. Remember, end-tidal CO2 tells you very little to nothing about oxygenation, tells you about chest rise and fall and ventilation. So procedural sedation, I use it day in and day out in the hospital. Morbidly obese patients that come out of the operating room that we put on a pain pump where we want to make sure they're still breathing and we want to actually walk away from the room, we put on nasal capnography. Last time I checked, when we do pre-hospital, so proud of me right now because he's not a huge fan of nasal capnography. We are providing one-to-one care. We're not saying, hey, you lie on the stretcher, I'm just going to grab a Chick-fil-A sandwich, I'll be right back, and then you go get your Chick-fil-A and you come back into the medic. That's not the way it works. Nasal capnography has a role in an ICU in a hospital setting because we can't hover over patients all the time. We can actually be, and we should be hovering over patients until we deliver them to definitive care. And so we can actually do what's called lay hands on people and do assessments and look for chest rise and fall and listen to lung sounds. So there's really no proven benefit of nasal capnography that I can find or any other reasonable clinician can find for its use in the field. I do believe that it can improve our diagnostics, though. And I do believe there is a role. And this is one example. If we could have gotten nasal capnography on, I would have felt a hell of a lot better about walking away and letting the extrication continue. I think there's a role for treating people with severe respiratory distress in the field. I think the most important place that we should start using it in Baltimore County is for when we provide what I was talking about in the hospital, which is procedural sedation. Just give me, this is a little off topic, but where do we provide procedural sedation or the equivalent of procedural sedation in Baltimore County? Well, there we go. How about excited delirium and Haldol administration, okay? Potential to suppress somebody's respiratory effort, potential to kill them. Coming out in July 2018, we're going to have ketamine available for those patients. Probably a good idea to put them on capnography. What about people that have seizures? Intranasal midazolam, IV, IM midazolam, sedating. And probably a good idea to have a greater level of vigilance over their respiratory effort and put them on nasal capnography. I would love to use it on most of my traumatic brain injury patients that are involved in trauma, where I'm looking at them, I think the chest is going up and down, I see a SAT, but they're also on a non-rebreather, so that can be very confusing because most people on a non-rebreather will have a high SAT, but that tells me nothing about chest rise and fall and ventilation. Might be nice to have those people on capnography. So what threshold should we consider intubation or supraglottic airway insertion during a rescue? So somebody's in a horrible wreck, they're trapped. If we're taking a board exam, at what GCS, if you can accurately calculate a GCS, are we taught to consider protecting the airway and airway? Right, so the mnemonic is GCS less than 8, intubate, but I would actually put in parentheses when we're in the EMS realm, consider intubation, because sometimes basic airway management is all we need. Initial assessment, there's a lot of mnemonics you can remember to kind of size up things at a crash, to remember how the extrication process proceeds. I heard Chief Robinson gave a talk to a group of people I was with on Friday, and he put up this one on the screen, CAN. What are the conditions, what actions have been taken, and what are the needs? And I really like that. It's simple, it's elegant. If I call for the Maryland State Police and they fly in, I think that if you can give them a quick, concise summary of the conditions, what actions you've taken, and what you need from them, if anything, it's a nice, concise little mnemonic to remember how to tell them what you need. Why don't we take a break here, and then we'll come back. It is 5 to the hour. Why don't we come back at 5 after the hour at 8:05. Going up to these rescues, you got to know your Alpha, Bravo, Charlie, Delta categorization. This really becomes much easier to memorize when you realize alphas are based on physiology, Bravos are based on anatomical problems, Charlies are based on mechanism of injury, 12, 18 inches, Deltas are based on all of the other, okay? And if you actually want to read a decent paper, go to the actual original paper published in 2011 that goes over how this was created, and it gives you a little more insight into the science behind it. So one of the things that I thought was important to put in here, because this happens a lot, is how do you know when to call priority 4, when it just isn't worth it or it ain't going to happen? And there are actually, there's been a lot of time put into this topic recently with regard to the concept of both withholding and terminating resuscitation. And it's a pretty controversial topic. This part, not so much. So when do you actually withhold resuscitation and just say priority 4, this is a recovery and not a rescue? So the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma in 2012 put out a paper, guidelines on how to do that when you pull up to a crash. And they came up with the following 6 things. It's okay to withhold resuscitation, i.e. not start cutting and not start doing if death is a predictable outcome. The patient's going to die. Number 2, obvious death. Are they decapitated? Do they have injuries that just aren't compatible with life? 3, is there, like in the medical world, evidence that the patient's been dead for a while? They hit a tree off of Green Spring Avenue. They haven't been seen for an hour. They've already got lividity. Then they specifically divided things into blunt and penetrating. I want to focus on blunt because that's what we're talking about tonight. Blunt trauma, extrication, complex rescue. The criteria for withholding or terminating resuscitation in blunt trauma is the patient has to be apneic, and the caveat with that is they have to have no reversible airway obstruction. So if you can actually get into the cab and do a jaw thrust and make sure they don't have anything obstructing their airway, that is preferable. They have to have no pulse, and both the blunt and penetrating withholding and terminating criteria, both in the literature, which nerds like me read, and in our Maryland protocol, actually has no EKG activity. How many times have you rolled up, called priority 4, and never put an EKG on somebody? That's okay if they have obvious signs of death. If it's something a little shady and we're not so sure, we should actually be putting on at least 2 leads across the heart, 3 leads preferably, and taking a look to see if there is any electrocardiographic activity. That is the consensus recommendation from every professional society, and it also appears in our guideline. Does that surprise anybody? No? The last time I did this was on 695. There was a motorcycle group of people that were traveling, and one wiped out and took a bunch with them, and there were dead bodies all over the east side of the Beltway on 695. And I came across a patient that I was pretty sure was dead, but he actually looked pretty normal. So I went through this, checked that he wasn't breathing, checked that he didn't have a pulse. Medic walked up, threw him on the monitor, confirmed asystole, priority 4. That's the way it should happen in a perfect world. The other thing to remember is that if the mechanism of injury doesn't correlate with the clinical conditions, that's somebody we should think a little more strongly about starting resuscitation. So there are criteria for when to not resuscitate people with blunt trauma and when to call it priority 4. Simplified, appropriate mechanism, no reversible blocked airway, nothing on the monitor that could be reversed, and injury is not compatible with life, priority 4. All right, so one of the other things to think about in complex rescues is this situation futile? Is a person going to survive? There have been a lot of calls that I've gone on where I look in, there may be, somebody saw a sign of life, but then I kind of look and I go, this isn't going to happen. The patient's injuries are just not compatible with life. What is the medical definition, statistically speaking, survival likelihood less than what is considered futility? Which one of these things up here? And which is considered, let's do some matching. What's futility? What is the chance of survival in the setting of traumatic arrest due to blunt trauma, which is what we're talking about tonight, compared with survival to discharge after out-of-hospital cardiac arrest for kids 1 through 11, and survival to discharge for out-of-hospital cardiac arrest for adults. What's considered futility up here? Test-taking skills. Cross out answers. If you have a less than 1% chance of surviving, it's considered futile. If you have a traumatic arrest right now on Reisterstown Road because you're in a car wreck and you go into trauma arrest due to blunt trauma, you have approximately a 2% chance of survival to hospital discharge. Kids 1 through 11 have the highest rates of survival in both traumatic and medical cardiac arrest. Oh, to be a kid again. And survival to discharge in adults out of hospital cardiac arrest, both medical and trauma, about 4.6%. Just a little FYI. So let's talk about patient care during rescue. This is a commercial truck that rolled on top of a car. You know that big hill coming down Northern Parkway to Falls Road right inside the Baltimore City line? The wheel of the truck is sitting here, right in kind of the center of the car. Dr. Pollack, when he gives a talk like this, will tell you that that's the only intersection in the state where there have been 2 GO team calls. Bad intersection. This is another view of it where Lutherville was called in special to do a lift. And this is what the patient looked like, kind of leaning over, head tilted down, medical provider here providing care while others are trying to get him out. So patient care during rescue, again, I can't emphasize enough proper PPE. Too many times EMS providers get in cars that don't have adequate PPE. You have to put down a tarp. So this actually, I thought, I'm going to coin this. It's going to be called the Vitberg tarp. I'm going to go on Shark Tank. I'm going to get rich, and I'm out of here. But then I started reading a lot of articles, and it appeared in every article that I read in Firehouse Magazine, GEMS. We all carry tarps, whether it be for overhaul, for MCI response. One of the things that we learned the very hard way on one of our recent calls, we had a GO team call with the Maryland State Police down in outside of Annapolis, head-on collision, very unfortunate situation where a mom got on the wrong way on 50 with her baby in the back seat, going highway speed about 75, hit a Mercedes SUV going about the same speed. In the process, actually transected another car, went head-on into the patient car that we were called to take care of. The mother died instantly. The baby was taken to Hopkins in critical condition, and our patient was very, very trapped and very, very sick. And we flew out there, and we bring a surgical bag, anesthesia bag, glide scope, yada, yada, yada. And I'll show you a picture of the call in a little bit. The car's on its side in a ditch, and we kind of spread our stuff out, and we're in the ditch. And then we finally got the guy out, and it's time to go. And we left everything on the side of the road. The University of Maryland was not very pleased with that when we left the glide scope and surgical bags because we were focused on getting to definitive care. Lesson learned, throw out a tarp, just the same way, and I thought it was done very well on Friday. They kind of staged all the extrication tools, kind of lined up near the front end of the truck. We kind of had our medical stuff on one side of the truck ready for the patient to be delivered, and had we done it a little better, could have thrown out a tarp, put all our bags on it, our cooler with our blood products, our medical bags, our backboard, so on and so forth. Optimal medical care may dictate the rate and pace of extrication. Balanced tactics is how it's referred to in the literature. Communicate between the people that are doing the cutting and providing care. You really want to avoid a lot of this stuff with wires when you're in the car, unless you absolutely need it or you're going to be there for a long time. What happened when we started transfusing this guy blood on Friday?
Well, once they put the guy on blood, and once they start all this stuff, I'm like, oh, here we go. It's always a problem because the monitor leads get cut, then I got to do paperwork and send it up to my boss, and IVs get pulled all the time. They get pulled all the time on regular calls, much less while they're entangled in a metal truck. Sure enough, they're trying to make this cut, and all of a sudden you see this line doing this, spraying blood everywhere. The line got cut, and the pressurized blood infusion is now spraying all over the providers. We didn't need the infusion at the time. We were fine, but they had it all over their turnout gear and everything. So as long as the patient's doing okay, I try to avoid all this stuff because it does nothing but get in your way while you're trying to extricate, and it just makes a mess.
So some of this stuff is obvious, but sometimes the obvious stuff needs stating. If you don't need a person on a monitor, let the rescue squad keep cutting and don't give them more obstacles to overcome. Good communication is essential for critically ill patients. Focus on rapid extrication, not cosmetic vehicle disassembly. This is something that I see a lot. It's the rate of extrication depends upon how sick the patient is. And there's a time and a place to take off a roof and do things real pretty. And I'm not going to lecture on that because I'm sure there's a few people that know a lot more about that than me in the room. But we want to get the patient out. That's our priority. Two things that I want to share with you that were tested and tested and tested on my EMS boards is that when you have a traumatic brain injury, as do a lot of these patients that are in blunt trauma in these rescues we go to, if you have a patient with TBI and they have a single episode of hypoxemia defined as a SAT less than 90%, their risk of mortality goes up by 150%. Evidence-based, proven, well written about in the literature. These are people that we cannot afford to let become hypoxic. They need a non-rebreather on their face. In recent years, we've gotten away from using oxygen for a lot of things. We don't put oxygen on people with MIs unless they're hypoxic and they need it. The group of people that absolutely need oxygen are people with traumatic brain injury. Same thing, if you have a traumatic brain injury patient that hit the dash, hit the inside compartment of the car, and they have a single episode of hypotension defined in our world as a systolic less than 90, also 150% increased risk of dying. These people are the folks, traumatic brain injury, are the one group of people that we treat in the field where we should be pushing the fluids, like we did in this case, maybe giving some blood and pushing blood pressure up. Most people that we treat with polytrauma, penetrating trauma, we actually err on the side of permissive hypotension so that things stop bleeding, get them into the OR, seal the holes. Be prepared for 3 game changers. I consider these the game changers in recent history. Intraosseous access. You got to have an intact limb to drill it into, though. Supraglottic airways. A little difficult to put in sometimes when people have facial trauma. And needle decompression. A lot of these people will have pneumothoraces that if you decompress them, they'll get transiently better. Another warning, hyperventilation. There is a good study that showed that hyperventilation of patients with traumatic brain injury imparts double the risk of dying. So if we get these people, either we're bagging them or we put a tube in, we're ventilating them, we want to avoid hyperventilation at all costs. If we intubate them, they have to be on continuous capnography. We target an end-tidal CO2 of 35 to 40. The only group of people that we should transiently hyperventilate are people with, hello, Bueller. People with, no, traumatic brain injury, we want to keep 35 to 40. Right, and pending signs of herniation. So if the brain is herniating, if they're starting to posture, that would be the one person that I would reserve hyperventilation for. Aggressive analgesia. Josh, you want to talk a little bit about the analgesics you guys carry and how you can treat the pain?
What do you got? Are you guys carrying fentanyl? Or you guys still have morphine? Fentanyl? So everyone went to fentanyl. Every once in a while we come across units that have morphine still. It's a great drug. We see the same thing in the field where folks are not getting pain management. I understand that there's always caution in the trauma environment with patients that are hemodynamically unstable, so we want to be careful that we don't drop their pressure. But we do have patients that can benefit from some fentanyl. And the ketamine, obviously it's going to be changing here where we'll be going into protocol here July? Yeah, so ketamine is an outstanding drug, and it's one of those drugs that kind of takes them out of reality for a few minutes, and it's dissociative, and we enjoy that. We use it for part of our induction for RSI, and it's been a great addition to our drug caveat.
The other thing is to be humane. There's been a few rescues I've been on where we're going to be there for a while, a younger patient, being humane about it and maybe helping allay some of the anxiety. Midazolam, which we carry right now, Versed, is a great anxiolytic, cures anxiety. Just by show of hands, anybody have a colonoscopy recently, endoscopy, any surgical procedure? Anybody receive midazolam? Old guys? Old guys? Come on, you've had a colonoscopy. Raise your damn hand. Awesome. All right. So Versed, I had major abdominal surgery when I was in residency, and I was in septic shock, and I was out of it. But then when they started wheeling me to the OR, I came back to reality. I said, holy cow, this is going down. This is happening. I'm going to be butt naked on an operating room table. I'm getting shaved. I'm getting operated on. And I started shaking a little bit, like this is actually happening. And then all of a sudden, I felt this profoundly warm, sunny sensation come over my body. It was as if I had no bills, no care in the world, and everything was just rainbows and unicorns. And I'd gotten 2 milligrams of Versed right into my IV. The anesthesiologist snuck up behind me, realized that at the time I was in my residency, I was going to have medical student syndrome. I was going to be all jacked up, asking too many questions. It was early in the morning. He didn't want to hear it. 2 of Versed, not a care in the world. So we have the ability to give Versed. We have the ability to give fentanyl. What do fentanyl and Versed have in common as far as how we can administer them? So yeah, right. So they can both be given via the intranasal route, which is handy if you can't get a line in somebody. Now, I would caution you that if you're thinking about giving an intranasal drug to somebody that's wrapped up, encased in a vehicle, I would pump the brakes and think about that and think maybe it might be better to have IV or IO access. But just remember, these things can be given IN, and they work very well intranasally. Avoid hypothermia. I can't state that enough. You got to keep these people warm, and if you can't keep them warm while you're effecting rescue, you have to be ready to keep them warm as soon as you get them out. When we were standing around on Friday waiting for our patient to be delivered 3 hours later, the CRNA we were with went back to the medic unit, pumped up the heat, and it was like, you know, when the baby comes out, they put him in a little toasty incubator. That's the way things were set up. Did nothing for us in the back of like a 80-degree medic unit, but it was the right thing to do for the patient. So patient care during rescue, I think, mimics tactical operations, massive hemorrhage tourniquets. You know, you don't necessarily have to tighten a tourniquet. You can often just stage a tourniquet. If you think you're going to be there for a while, or you're not sure if that thing is how much it's bleeding, and you need to get a little more exposure, you can stage a tourniquet on a proximal extremity and then tighten it if you need to, or you can just straight up tighten it from the get-go and worry about it later. Hemostatic agents, or we can use those in Baltimore County, okay? So if your company wants to buy quick clot, whatever, combat gauze, A-okay. Pressure dressings, you got to know how to apply them. That should be your first treatment priority whenever you get into the cab with these patients. If they have massive hemorrhage, you got to treat it. Without blood, there's no airway or anything else. Airway, there are limitations to how we secure an airway. It's very difficult to intubate people on the street. It's even more difficult to intubate them in the cab of a truck or in a car that's upside down. Let's just do a little show and tell. Gentry, would you mind getting out the King Vision, and would you mind just showing people? So I'm going to have Josh show you the device that they're using up in the air, and I'm going to show you what we have in Baltimore County, and I just want to point out some of the limitations that you might encounter with both of the devices during rescue.
So MSP was kind enough to purchase a bunch of UE scopes. This is something relatively new on the market. There's been a variety of things that we've tried over the years and looked into. In our environment, in the back of an aircraft, we wanted the ability to intubate easily. What we did was we bought the King Vision a few years ago. We were using the channel blades, which you see right there, and the unchanneled blades. And a lot of times there was frustration because with the protocols we have to record this. And so we had rigged up a little portable DVR with 6 feet of cable, and as soon as I got everything set up and the monitor ready to go, someone would walk by to get something and trip and then yank it out of my hand. So we had so many problems with, there's limitations with excessive amounts of blood in the airway, the fact that we were only allowed to use this on adults, and the screen is fixed. So when we went to the UE scope here recently, the advantage is there are a variety of sizes. We can use this in the pediatric population. The other thing is sometimes, I don't know if you mentioned it yet about the sunlight coming in through the car. When there's challenges with bright light, again, you're stuck with, this is all I've got. The screen swivels side to side. It can focus down so you can get the sunlight out of it. And all the recording buttons are right here. And so that's one thing that...
So just for practical purposes, so we're going to be trialing this device in Baltimore County. And for many of the reasons Josh just pointed out, the maneuverability of the screen. So the high-end, so the thing that I don't have in my hand right now is the GlideScope Ranger, which is kind of military battleground tested. It has kind of a separate monitor, a wand, and then the part of the device that you put in the patient's mouth. This is kind of emerging as the next best thing because of the maneuverability of the screen. You can imagine that if he's trapped in a vehicle and Lieutenant Fitzpatrick pulls up and wants to intubate him in the car, this is going to go in like this. The screen is fixed. He has to be either standing in the back seat because this thing doesn't swivel. So the limitation of the King Vision, which our supervisors carry in Baltimore County, is the screen is fixed. It's a beautiful organic LED screen. It's bright. You can see the anatomy, but there's been problems with it. The fixed position being one for complex rescue, which is what we're talking about tonight. And the other thing, too, is the ET tubes don't slide as nicely as we would like to, even with a lot of lube through these channels. What's kind of emerging in the safe chat rooms that I go to talk about these things is that these sorts of devices, which really mimic the way we perform direct laryngoscopy and give us both a direct view and kind of an indirect view on the screen, are really kind of emerging as video devices of choice in the pre-hospital arena compared to indirect devices where you just kind of rotate this in. You don't see the cords other than what you see on the screen. So this is clearly going to win in a tight spot.
And the other thing is to mention that with suctioning, with the King Vision, you're basically sticking in midline, and if you have someone who's got a big burly chest, or you've got a C-collar on, or someone's holding crate pressure for you, it's really cumbersome trying to get that thing in their airway just because of its shape. And what we found was that we were having a lot of problems sticking, allowing it to fit in all these different folks. And with this, again, we have the blade size, as you said. We can get in there and sweep the tongue. But the big thing is that what do you see when you open an airway? Is it nice and clean and shiny and good view of the cords? No. I always tell all my new providers, expect about 90% of your patients you're going to have vomit, blood, secretions, teeth. There's going to be all kinds of stuff. So go in, leave the tube on the side, on their chest. Go in with suction right away, or keep a free hand if you need to do laryngeal manipulation. But this thing here, you can go in, and it leaves you plenty of room for suctioning. And that's huge, and especially some of these traumatic patients that have upper airway hemorrhaging. And again, we've got a smaller size for peds, and we're going to be getting a little bit smaller.
While we're on the topic of airway, which supraglottic airway do we carry in Baltimore County primarily? King Airways, King LTDs. Do you want to show us which supraglottic airway you guys are using?
Again, we get new equipment when old equipment goes by the wayside. They had to change combi tube up many years because of the latex issue, and then we went with the Easy Tube, which was essentially the same design. Easy Tube, we're not buying those anymore. They stopped making them. So now we've got this air cube blocker. It was tested extensively at Hopkins, especially in their peds environment. And the advantage here is that it's a little more rigid than your standard LMA. It's got a little harder surface on the back. It's got a small ramp inside the tube. The design is that ultimately the anesthesiologist can come in if we have a patient with a nasty airway, especially in the pediatric population. This is in place. It's providing good ventilation and oxygenation. However, when they need to intubate, instead of pulling this thing out like any of the other devices, they can go in with a fiber optic scope and advance an ET tube in place without the patient having periods of hypoxia. So it's been really nice. It's more rigid. It's basically the bite block. It's also got a channel on the side where we can advance down an orogastric tube. And really, you just put about 3-4 cc's in the pilot cuff. The soft tissues in the airway surround around this, and other than that, lube everything up, and it sits right in place. You do have to secure these, but the nice thing is if it pops out like an ET tube, everyone starts to panic. We've lost end-tidal CO2 waveform, et cetera, et cetera. We just had one of the guys in Salisbury use this weekend, pushed it straight in, end-tidal, SATs, everything was perfect. And the folks on the ground down in Virginia were having a heck of a time securing an airway with the King because of the jagged teeth. It tore the cuffs. So this is what we're using. So if you see us pull this out in the back of the medic, it'll be familiar.
So massive hemorrhage, first priority. Airway, we talked a little bit about some airway tools. One of the things we were talking about that tends to be common with all video devices, and we encountered on the road in Annapolis under the blazing sun, is when you have bright sunlight, you kind of lose the contrast of that bright video screen, and that can be challenging even with like a turnout gear over your head. Respirations, sometimes all you need is just a nasopharyngeal airway. It's one of the best tools we have available to us. Bag valve mask ventilation, hard to do in a vehicle, and needle decompression. I want you to remember that's not the end game. That's a very, very temporizing maneuver. That patient needs a chest tube. Circulation, timing of IV access in a complex rescue, We decided on Friday, somewhere around the 1 hour marker, probably a good idea to get in there and get some access. Proximal IO devices are generally going to be your go-to, unless you can get a good, robust peripheral IV, and we'll talk about that in a sec. And we talked about hypothermia. So just a few quick practical questions. When should you throw on tourniquets? If they're bleeding and you can't see the end of the limb and there's a lot of blood, put on a tourniquet. Call dispatch or tell whoever's kind of recording for you at the scene what time the tourniquet went on. I guarantee you're not going to find your Sharpie and put a time on their head or a time on the tourniquet. When should you consider supraglottic airway insertion or intubation? GCS lesson 8 makes you think about intubation. We underutilize supraglottic airways. Maybe not the best thing to put in people with significant facial trauma, but something that we should be very familiar with. And I think we might have to start looking at alternatives to the King LT. When should you get at vascular access? Again, this is a collaborative conversation between the people trying to effect rescue and the medical folks. How long are you going to be there? What's the patient's condition? Can I get in the car? Is the person in the car going to get a line in the patient? Even if I think I can get a peripheral IV, I generally reach for and put in a proximal humerus IO because it's a sure thing. And I want to, if I go in and I'm creating a timeout from the people that are trying to open the compartment up and get a patient out, I want to get my line in. I want it to stay in. IOs generally stay in a lot better than peripheral IVs, which can get kind of sweated out. When should you start the crush protocol? So are any paramedics in the room? Raise your hand. What are the 3 medications that are part of the crush protocol in the state of Maryland? Bicarb, calcium, and albuterol. Easy. Cutting the patient out of the car, like the one on Full Moon Saloon, put a mask on his face, start nebulizing albuterol. Albuterol pushes potassium back into the cells. Calcium chloride does what? Protects the heart from the dangers of hyperkalemia. And bicarb, a 50 milliequivalent push or a drip, does what? It also pushes potassium back into the cell. Why do people die when they're crushed for a long time? All the potassium in the cells and the muscle beds gets released. It floods the circulation. When you get a lethal injection in a couple states, what do they give you? They give you potassium chloride. That's why people die early when they're crushed, is from hyperkalemia. Start the pin for 10 to 20 minutes. As with most rescues we have locally, do not need the crush protocol. You're not getting significant rhabdomyolysis. You're not getting crush syndrome if you're pinned for 10 minutes. If you're 20, 30 minutes in and it's still not looking like the patient's getting out, start the crush protocol. Okay? It's better to start it early than to not do it at all. Packed red blood cell transfusion, I think, can be very, very, very life-saving and important for folks that are trapped for a long time. We gave the guy blood on Friday because he was trapped for 3 hours. He had massive orthopedic trauma, was likely having hemorrhagic shock, bleeding into his pelvis, into his thigh compartments. So the only way you're going to get blood is again, by calling for the GO team. We'll bring, at this point, we usually bring 3 to 4 units of packed red blood cells and 3 to 4 units of fresh frozen plasma. What BP should I target? So if somebody has a traumatic brain injury, we don't want the blood pressure to fall less than 90 ever. If a person has a traumatic brain injury, we don't want the SAT to fall less than 90%. Both of those things, if they happen, increase mortality by 150%. Good. When is it appropriate to administer analgesics or amnestics? Which one should I use? We talked a little bit about, we have fentanyl, we have Versed in Baltimore County. Those have to be weighed against what's the patient's respiratory status. If MSP arrives, they have ketamine. Ketamine is a wonderful analgesic. Do you guys use ketamine for analgesia or just in your RSI sequence?
RSI right now.
Okay.
And unless we want for pain management, then we can call the hospital.
Okay. So ketamine is a wonderful analgesic too. It's also a good bronchodilator. Different talk. Should I monitor the patient? Again, if you don't need to put the noodles and the wires in the car, don't do it. Make sure that if you do something, an airway, a line, an IO, that it's really secure and that we don't have a blood bag on a pressure infuser running through an IO, transected, and blood spraying everywhere. So make sure everything's very secure and you have dedicated people to kind of hold those things in place. What can Maryland State Police provide that we in Baltimore County Fire Department as paramedics cannot? I think it goes without saying, but I'll let Josh tell you what they can do that we can't.
We fly faster than the medic drives. That's pretty much it.
There you go.
No, again, we are bound by the same protocols that you guys have. Some of us have gone and gotten other education on the side and whatnot, but as it stands right now in Maryland, we function under the Maryland protocols as paramedics. Okay. And so we, we have the RSI medications. We have etomidate, midazolam, and ketamine for sedation. And then we also have succinylcholine for the paralysis, and then we also have vecuronium if we need long-term paralysis. That's perfect for the patients with the intracranial pressure building up, people that we don't want bucking against their ventilations or our ventilations for them, so we'll give them VEC. And, but the big thing is, you know, we're always trying little devices and tools and stuff like that, the things to make an impact on a patient. We carry the Flex guys or the Bougies. They worked wonderful. We just started using this new device here. If you guys want to look at it later on. What's an issue that we have monitoring patients that are in shock? What's a vital sign that it's hard to get with the monitor? Someone say? Exactly. So you got someone who's got poor perfusion, or the other day the gentleman who's laying there in fuel-soaked clothes, freezing cold. What was it, like 40 to 35 degrees? Okay. So you've got a guy that you put a pulse ox on his finger, or you put the little piece of tape on, and you don't get anything, or you get really poor readings. This device here is nasal alar. It clamps basically on the side of someone's nose, and there are vessels that are running from the internal carotids to this area, and every time I've used this, and any of my colleagues that have used this on patients with poor perfusion, the monitor would not pick up through standard pulse ox reading. This picked up like almost immediately. It stays out of the way. It's got a very flat cable here. If you need to ventilate the patient, it doesn't interfere with someone maybe even on a CPAP mask, or for BVM, it doesn't get in the way. So feel free to look at that later. It connects right to your normal pulse ox. And, you know, so little things like that. But for the most part, we're functioning under the same protocols that you guys do.
All right, we're going to put this into a little bit of a faster pace. Look in the Go Team ad. So a lot of people think about the Go Team as just a potential limb amputation service. That's not the case. Again, we can bring blood products. We can bring pretty much everything you might find in an ICU emergency right to the patient's side. And are there guidelines for limb amputation? Yes, there are. I'll show those to you in just a sec. A little bit about airway. We'll fly through this slide, but I just got to tell you straight up, and you know this already, every academic article that's come out about pre-hospital intubation, except for one recent article, has not been in our favor as paramedics. I'm not going to read through this. I'll send you guys my slides if you want. And you can only imagine that now we extrapolate to, can we perform intubation as paramedics successfully in the confined space of complex rescues? And the answer is the academic peer-reviewed literature would say probably not. And that's unfortunate, but there's thankfully some new papers that are coming out that's showing that we can actually maybe intubate different talk. Airway, just a couple quick things. You always have to have basic airway management before advanced airway management. Any patient that's hypoxic or potentially hypoxic needs oxygen, particularly if they have traumatic brain injury. There's really no literature on supraglottic airway insertion or intubation procedures during complex rescue. It's a call-by-call assessment. We underutilize supraglottic airways, and we probably have to look at those a little bit more. If you put in a supraglottic airway, it has to be secured somehow so it doesn't pop out. National consensus guidelines is that every EMS agency should cover or carry at least one supraglottic airway. We don't know what the outcomes are related to the use of supraglottic airways in arrest, either trauma or medical. There are really no large-scale studies that look at supraglottic airways in pediatric patients. There was a good reassuring study in 2011 looking at King LTs inserted by an urban BLS first responder system. They did that as their primary airway for cardiac arrest, and they found that the first pass success rate in detection of end-tidal CO2, oxygenating and ventilating a patient, was 5 times better than when paramedics attempted intubation. So there probably is a role for our basic providers to be doing supraglottic airways. Anytime we put an airway in, whether it be in a car, right outside the car, on the way to the hospital, confirmation of the airway is dynamic. It's not a one-time static thing. It's ongoing, especially in these situations where we're moving patients from multiple phases of care. We want waveform capnography. We talked a little bit about video laryngoscopy. This was a call on the side of Route 50 near Annapolis. This was the vehicle on its side in a ditch. Hard to appreciate. This was a CRNA. This is me with my big white helmet. And what we wound up doing was calling for a wrecker, and the patient came to be still trapped but seated upright. We could not intubate him nobody could intubate him. I tried, the CRNA tried. with the video devices, there was just too much sunlight to even appreciate an image on the screen. So we made a quick command decision to do a tracheostomy. And he was actually seated in the car. John was holding his head. John actually, so the trooper on the call stayed in the car as the wrecker righted the vehicle, just kind of held him somewhat stable. And then as soon as the car came up to sit on 4 wheels or pseudo 4 wheels, I came in with a blade and just put in, made an incision, burrowed down to his trachea, and put in a tracheostomy. So if you make decisions, difficult decisions, just commit to them and go for them. And video devices will be difficult to use in these situations. A little bit about vascular access. So the way vascular access works is the bigger it is and the shorter it is, the more flow you're going to get. So a proximal humerus IO, if you drill into the proximus like we did on the call on Friday, you can get 5 liters per hour into a patient. It's basically equivalent to a central line. If you go into the prox tibia, which is often very difficult because usually the legs get trapped in these accidents, you can only give about 1 liter per hour. And there are some systems that actually use sternal IOs, which can actually give more than a proximal humerus IO. It takes 2 seconds for something to go from an IO in the shoulder to the central circulation. It's a wonderful, wonderful resuscitation line. Hyperkalemia, you got to know how to treat it, especially if the patient's going to be trapped for a while. We talked about the 3 drugs: calcium chloride to stabilize the heart, bicarb, and albuterol to push the K back into the cell. So early death associated with crush injury is due to what? When people get crushed and they die early, i.e. when we're taking care of them in the trapped vehicle, what are they dying due to, if not due to the polytrauma? They're dying due to hyperkalemia, elevated potassium. Late death, why do people that are crushed that we actually get out 3 hours later, and I'll tell you it's happening right now to our patient that we took care of on Friday, and hopefully he won't die, but what do they develop that puts them at great risk for death and causes late death? Compartment syndrome, and what goes along with that? I saw a PA here. Renal failure. So when you break down your muscle beds and you release all the myoglobin in your muscle that clogs up your kidney, our patient from Friday, his myoglobin levels and CPK levels just kept going up, 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 up. And although he came in and his creatinine, the measure of his kidney function, was okay when he got there and he was making urine, over the first day he stopped making urine. US dialysis. 3 things we talked about: calcium, bicarb, and albuterol. And actually, there's a 4th thing, which is just good old IV fluids. Most of these people need liters and liters of fluid. And what drug-drug interaction do you have to worry about in that scenario? What drugs are potentially bad to mix? The calcium and the bicarb, right? So you can get calcium chloride precipitating in the vessel, and that's usually frowned upon. I'm going to just say a couple quick things. Go teams around the country were born out of the potential need to amputate limbs, but there actually aren't a lot of them in existence. The key principle with limb amputation is life over limb. Usually it's due to a trapped extremity. Usually the vast majority of calls are for motor vehicle crashes, and I'm talking about both in Maryland and around the country. Secondary reasons are industrial or farming accidents, and rarely due to structural collapse. There are actually 4 evidence-based written about indications to amputate limbs in the field. The first 2 are straightforward. You have to commit and you have to do it. The second 2 is a collaborative discussion between the incident commander, the Maryland State Police, the physician on scene, and it has to be made kind of as a group. Priority 1, in trapped extremity, extrication is not going to happen rapidly. The patient's hypotensive and they're not responding to anything you're doing to them. You're giving them fluid, you're giving them blood, you've controlled hemorrhage, you've secured their airway, and they're not responding and they're becoming more and more hypotensive. That's an indication to, if you're not getting them out quickly, to consider a amputation. Class 2, trapped extremity, extrication isn't going to occur rapidly, and there's something that's going to fall on everybody's head and kill all of you. Do it and go. 3 and 4 is a collaborative conversation. Trapped, you're going to be there forever. The patient was initially hypotensive, but now they're responding to things that you're doing in the field. Take your time. Don't take your time, but continue trying to get them extricated. And 4, trapped extremity, hemodynamics are completely normal. They were never hypotensive. Extrication is likely, but it's going to take hours and hours and hours. So 1 and 2 are priorities to do it. 3 and 4 are indications to step back and have a little bit of collaborative discussion. If you don't know, There's a protocol that talks about how to activate us. The most important things that I think we do are packed red blood cell transfusion. Most of our patients we're talking about today are in hemorrhagic shock. Some surgical interventions, chest tube insertion, Foley insertion, basically bringing critical care to the roadside. Consists of a doctor, a CRNA, and the Maryland State Police. The biggest thing we do, 90% of the call, is I reassure people. I rub that, well, not after Harvey, but I used to kind of rub their shoulders and say, you're doing a good job. We do carry tools for amputation. I did pull this out once in my 8-year career. It's a giggly saw. It was for the call, pull his leg really hard, and it popped out. I was very glad because it would have involved a lot of paperwork had I had to actually cut something. If you do amputate something, which actually was the case in front of the Blue Moon Saloon, part of that guy's body fell off. Don't remember which part, but it did. Sealed plastic bag, you want to keep it dry. You want to place it on top of ice. You don't want to freeze the body part. You don't want to submerge it in water. And don't forget to transport it, which is what we did down on Route 140. We had to have a little UPS guy deliver it to shock trauma. All right. Just for the record, there's been one field amputation in the state of Maryland, and it was actually a volunteer down in Waldorf, Maryland, that was responding to a call. A volunteer, deer was in the middle of the road, swerved off the road, hit a telephone pole. Car kind of was very damaged, kind of broke in half. Leg was trapped underneath the dashboard. It was like 20 degrees outside, and this is actually a picture of the patient in the OR after arrival and application of an external fixator. Post-extrication care, so here we are. Always good, always a great day when there's 2 doctors on scene telling you how to do your job. This is the post-extrication phase of care, and what I want to say about this is where I feel we can improve as a system. On-scene time after extrication. Austin Travis County EMS, really cool EMS system. They're having a little bit of problems right now if you know anything about them, but they have a dashboard, which I would love to see in Baltimore County, and they publicly report their performance. They have performance update and publicly report. So paramedic engine 19, I think, right? You would be included in that data. What is your compression fraction for cardiac arrest? I could, as a citizen of this jurisdiction, click on here. I can look at overall system performance. I can go by first due. I can look at engine 19's first due and see what their CPR fraction is, what their out-of-hospital cardiac arrest survival rate is. They publish this, and I think we can do that locally. One of the things that you can click on is their trauma scene time, and I would argue that we don't really do well with the 10 to 15-minute time. They hold 15-minute as their standard. This is called a control chart or a run chart, and they track each quarter their average scene time for traumas, and any time the scene time exceeds 1 or 2 standard deviations, the medical director looks at the reports, he sits down with providers, and he tries to figure out what's wrong with the system and how to make it better. They also report it by percentage. Their goal is that 90% of the time, they will be off the scene on their way to definitive care within 15 minutes. This is just one of about 20 metrics that they publicly report, and you can go in. I'd urge you, if you have a phone, type in Austin Travis County EMS, awesome system dashboard. Rich Schenning has done a ton of stuff in the few weeks that he's been our EMS medical director, and this is one of the things that he's working on, and I hope to see it real soon. I want to talk a little bit about pelvic binders.
Do you guys carry them?
Yes,
Okay. The big thing with the pelvic binders is if you suspect someone has a pelvic fracture, if you're palpating, they've got any type of bleeding, genitourinary area, vaginal bleeding from trauma, put a pelvic binder. Sorry. Put a pelvic binder on. Okay. We want to stabilize the pelvis. We want to minimize bleeding. I'm not going to, everyone here that is a mail-in provider has either seen them or they've applied them, but they're very useful. The biggest thing is that we see coming in after they've been applied or they haven't been applied is the improper position. They need to be on the greater trochanters and compressing equally. Sometimes they're up around the stomach, sometimes they're way down low, so we don't want to bend the pelvis in an area that's going to exacerbate the pelvic binder.
Don't forget to lay it on your backboard as you're pulling the patient out and have it ready to deploy, ready to go. Because once you start cinching down spider straps, it's going to be a pain in the ass to undo all that and slip a pelvic binder underneath. And this all comes with good training and good rehearsal. Transfer of care. So let me just tell you a little bit about the call that we went on the other day. This was the guy. He came into the trauma bay. He had a lactate of 16. A lactate above 2 is considered abnormal. Progressive EMS systems actually do point-of-care lactate measurement. You need a microliter of blood just like you would for a finger stick, and you can actually measure a patient's lactate in the field. Above 2 is abnormal. Above 4 is associated with shock. 16 is FUBAR. Myoglobin is a byproduct of muscle breakdown. As the muscles break down, they release the protein myoglobin. His went up, 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 and when I looked this morning, it was 140,000. Less than, it should be undetectable in your blood. This clogged his kidneys, and as a result, now he stopped making urine, and he's on continuous dialysis. His gas, when he arrived, he had been trapped for 3 hours, 2 hours of which he had a deceased patient tightly pinned across his chest. So he had a pH of 6.8 due to his lactate being so high, having a metabolic acidosis. He had a normal CO2, but he shouldn't have had a normal CO2. He should have been hyperventilating and compensating and bringing his pH up, but he simply couldn't do that because he had the other deceased patient across his chest. He had multiple fractures, most of his fractures because he was the passenger in this truck and it tilted onto the passenger side, were along the right side of his body. Bilateral pelvic fractures, he had a right femur fracture, right knee, right lower extremity fractures, and actually scattered fractures on the left side. The fractures on the left side were actually due to the deceased patient kind of pushing against him between him and the dashboard in the back seat. So the last thing I want to talk about in the last 5 minutes is one of the phases I didn't put up here was debrief. So 2 GO team calls ago, we were out in Morgansville, which is near Hagerstown, with Trooper 3. It was a motor vehicle crash rollover. And just to fast forward, this is what we saw when we got there. We saw everything was tightly closed here, and all we saw was a foot coming through the floorboard here, right around the wheel well. This was one of the kind of a hot rod type car, had a lot of modification done. It had the bat doors on it, which posed a little bit of a challenge to get off. A lot of titanium parts that were difficult to cut through. When they finally got the door off, foot stayed here, body splayed out onto the floor. And we wound up giving him blood, flew him to trauma, and at trauma they did something called REBOA, which I'm going to show you in a minute what that is, just to excite you about being in the game and being in EMS. He arrested on arrival. They did this thing called a resuscitative endovascular balloon occlusion of the aorta, REBOA, and he came back to life, and 2 to 3 weeks later he walked out of the hospital neurologically intact. What I thought was really good about this was we did a debrief, and you should debrief not only these crazy calls, but you should debrief every call if you're an officer. Talk about even the routine, mundane stuff. There's always something to learn from every call. This call, we were in a classroom like this, and we did a debrief, and then we went out to the engine bay. The officers there were able to reacquire the car from the insurance company, set it up on the floor of the engine bay with some stabilization, and then the second part of the debrief, we actually walked around the vehicle, formed a little kumbaya circle, and then kind of went around the circle, and everybody gave their 2 cents about what they saw when they got there, how they affected rescue, how they took care of the patient. It was very, very excellent, very, very meaningful, and one of the best reviews I've ever been a part of, including positioning the mannequin in the position that we found him. I want to say 1 or 2 words about critical incident stress management that I learned recently studying for my boards. So a lot of this stuff can be heavy, and it was heavy for me, the guy that I told you about on Route 50 that was hit in the wrong direction by the young woman and her baby. That stuck with me for a little while because he was very alive when I got there, and he died as we were taking care of him. This stuff can get to you even after many years of doing it. But what I want you to know is that there are a lot of studies that have come out that show mandatory critical incident stress debriefing is actually likely to be harmful. And the better approach is to have a non-intrusive system in place, to actually just look out for each other. Look at the people you work with when you come into work. Look at the people that you're friendly with that you see when you come into the firehouse. A good critical incident system is available immediately, but it's not intrusive. It's being supportive, compassionate, and really watchful waiting and looking at people and seeing if they're having problems. Providing treatment to those that need it at the level they need it, but not everybody benefits from critical incident stress debriefing. It can't be mandated. And you have to make sure that if somebody does need help, that you get them to the right people, that it isn't helping peers is a great thing. I don't want to underestimate that or devalue that. But when somebody needs help, you need to get them to somebody trained in PTSD that can help them. To nerd out a little bit, there's actually a right way to do this. So there's something called the TSQ, the Trauma Screening Questionnaire. This is the National Fallen Firefighter Foundation puts on courses where they'll teach you this. And there's a little screening questionnaire that if you have more than 6 positives to this, and you kind of look at every algorithm that's been published about how to help, the best way after a critical event is to do a hot wash, sit down and say, hey, how'd it go? What could we have done better? Who do we need to share our learning with? And that's usually all that's required. And if resolution's achieved, done, protocol terminates. If you think somebody's having a problem, you want to do this TSQ screen, and if they score above a 6, then you want to send them for a more complete assessment, and it has to be with a specialist who will really be able to help them. The good thing about people that suffer from PTSD in the fire service is it usually only involves short treatment, 12 to 25 sessions. You're not going to be in therapy for the rest of your life usually. And most people that develop PTSD due to difficult calls in the fire service have a whole lot of other issues that they're going to benefit from by going to a professional. So we'll finish with talking about the future. So the patient that we talked about got delivered to the TRU, and he had a blood pressure of like 58, and he was in a bad way. Did he arrest? Okay. The one before that I delivered from Morgansville in Hagerstown arrested as we got into the trauma bay. Back in the day, all of these patients, if they arrested on the way into the TRU, would have their chest open, and they have a thoracotomy. You'd open up the chest, kind of work your way through the lung, and put a clamp across the aorta, and basically simple plumbing. You would stop blood flow to all the things that were bleeding in the abdomen from blunt trauma, into the pelvis, into the open femurs. If you were a really unlucky bastard, you'd get what's called the clamshell. They would go from the left and extend it across to the right, and they would lift your chest cage up, much like a clamshell, okay? That way they would have complete access to your diaphragm, both of your lungs, your heart. And this was, when I was training between 2001 to 2006 at Shock Trauma, this was a nightly occurrence when I was on call. This is what I would prefer if I were in that situation. This is Reboa. Josh has seen it, I've seen it, and I've seen it save people's lives. Resuscitated endovascular balloon occlusion of the aorta. This is what it looks like. A little cleaner and smaller than a thoracotomy. Take an ultrasound, you find the common femoral artery. You put in what's called an introducer, which is basically a long, hollow IV. And then through that introducer, you snake this guy right here. And then you push it up into zone 1, which usually sits right around the diaphragm, or zone 3, which is lower in the pelvis near the bifurcation of the aorta. And you inflate the balloon, and what does it do? It stops distal blood flow. So now instead of opening the chest and cross-clamping the aorta, I have a small, not small, it's pretty big actually, a decent-sized French catheter in the groin, a little piece of spaghetti that goes up, and a balloon that gets inflated. Sign me up for this and not the other one. This is what I want if I ever need it. This is what it looks like when it's in somebody's thigh. Zone 1 is for people that are exsanguinating into the abdomen. It gets blown up right around the diaphragm. Zone 3 is for people that have significant pelvic and femur fractures that are exsanguinating into those. This is what the x-ray looks like. To confirm, they usually put a little water and contrast into that balloon. They come in, they shoot the portable x-ray, make sure it's in the right position. This is done in the field. In where? Europe, because they do everything first. In London, the helicopter EMS providers, the MIEMSS providers, do this. And they've actually been doing it for quite some time, and they're actually showing and collecting data showing good outcomes for when this is done at the point of injury rather than the 20, 30-minute flight sometimes back to shock trauma. And this is the helicopter EMS crew in London practicing it on a sim guy. All right. So last few slides, you don't need to be an ALS provider to do any of this stuff and save somebody's life. The next slide I'm going to show you, Larry's actually sitting right here. So 9 years ago, when I went on my first call in Chestnut Ridge as a non-medical director, as just a peon, was the first time in my career. So it was the first time in my career I ever saw free-flowing CSF coming out of a child's ears. Child, very benign injury, well, not so benign, on the driveway, on the bike, dumped the bike, hit her head just hard enough, and she had a traumatic brain injury, and she had CSF coming out of her ears, clear as day. And I got very much into doctor mode, and I was thinking about airway management and pediatric intubation and IV access and all the things that ALS providers like to think about. And Larry, who's right here, goes, Want to call a trooper and get this kid to Hopkins pretty quick? Great idea. Probably would have taken me another 5 to 10 minutes with my blinders on to think about that. So if you're a BLS provider in these really tricky, complex situations, don't underestimate how important you can be. BLS providers, we all know, save ALS providers' lives every day. So you got to know, just to review, you got to know about pelvic binders. You got to know your crush protocol if you're an ALS provider. If you're responding to any call, particularly if you're going to be first on scene or sitting in the front seat, you have to be well-versed in ICS and know how to assume command. You have to know your trauma decision tree and how to prioritize and categorize patients. And you have to know what your supplemental resources are, be them MSP, the GO team, a heavy-duty wrecker, MDE, whatever. I'm not going to read down this slide. This is everything we talked about tonight. What I'd like to do is just open it up to comments, especially, again, from the old guys and the people with white shirts and the people that have taught me over the years, or any questions for either Josh or myself. And I just want to say thank you guys for bearing with us for 2 hours. We appreciate you guys coming out to this. Any questions, comments, feelings, emotions, emojis, anything? Everybody ready to go home and watch football? Yes? Gentry.
Because was the patient from the other day treated for crush? We had discussed that. They're in the process of extricating the patient, and the CRNA went back to their bag and realized that they took out the sodium bicarb. So that was one of the issues.
Yeah, so we should have. All right. So we actually wound up giving him blood. We put in an IO and we pressured in a unit of blood, which I'd like to think saved his life. It made me feel better that night when I got home. But we could have hung some bicarb. It was very difficult, and I think after our red blood cell infusion line got cut and was spraying around like Freddy Krueger style, I think that's when we decided to back off a little bit and let extrication proceed and kind of get ready to do things on the way out.
And just to add to that, when we were talking about transfer of care, when they brought the patient out, our game plan was we've got everything set up, cut his clothes off immediately, get him deconned, wipe him down, get him on the board. We are carrying a life blanket. I'm not sure if you guys have them on your units, but it's essentially a sleeping bag to prevent hypothermia. Or in the summertime, we can take the insulated portion out, and it just keeps them contained, keeps all their body fluids contained, and it's great. Again, it prevents hypothermia. You can get cold in the summertime. But the transition, the plan was, as they brought him out, we're going to quickly clean him up. CRNA went back to the medic to set up another IV and to set up a unit of blood. So all of this happened very fluidly. Back I got in, I'm like, where's the driver? Let's go to the LZ, which was only a mile down the road. So by the time the blood was on, we had the patient ready to go, and it was a matter of parking and getting to the aircraft.
If I could have done it differently, I would have hopped back in and given him an ample bicarb, just pushed through his IO. That was my mistake.
I just want to add two things. Sure. One thing is with fluid resuscitation, put a pressure infuser on. Even through a 20 gauge, you can pump some fluid in someone. The other thing that we see is a lot of times you guys go in and start med locks, and it's a small, very small lumen, and we're trying to pump a lot of fluid through. So some of the med locks are more driven by just providing medication, but those that we can use that are larger lumen, put that on the patient. So again, if maybe he didn't do an IO, he's like, oh shoot, I got his arm right here, I'll just start a med lock. Well, we can run fluid, we can disconnect that fluid and proceed with the extrication, and if he needs to reconnect, then great. But that really cuts down on the flow. The other thing is with oxygenation, we talked about the fact that periods of hypoxia, whether it's during intubation or during traumatic injury, one thing that we are doing in MSP, and we just had a work group study with all the RSI jurisdictions across the state, is that we're doing this no DSAP procedure. I'm not sure if you guys are familiar, but essentially providing, if you're doing bag valve mask ventilation to anyone, you're putting a nasal cannula on, turning up to 15 liters per minute. So we're maximizing oxygenation prior to going in and discontinuing the BVM to intubate. So it's providing passive oxygenation. And what we found is that if we slow up our sequence of intubation and bag up with a little bit of PEEP on the bag valve mask and that additional oxygenation that's in the oropharynx, then when the patient is being intubated, they're not going to have a period of desaturation. And we found it very useful. A lot of these RSI work groups, they love it. And so we'll walk in and say, hey, go ahead and put them on a nasal cannula and crank it up, 15 liters. And it minimizes.
Tandem with the bagging?
Yes, in tandem. So you put that on, and you need 2 sources of oxygen, but it's just for the period of intubation. And once that's done, and then we put the capnography on the tube. But I found myself, I've done several airways, periods of oxygenation or deoxygenation have really cut down.
If you want to read up on that, the term in the literature that's thrown around when that technique is discussed is delayed sequence intubation. It's not for slow people. It's for just taking your time and pre-oxygenating the patient a little bit better. Delayed sequence intubation. Any other questions, comments? Sir?
Yeah. One thing you brought up about having blinders on and stuff like that, where you get there and you get focused on one thing. The EMT, I mean, in all my experience, if you got a mass casualty or anything that's going like that, you want to make sure that the EMT does the triage. Because the ambulance providers, as soon as you got on a call, and see something you want to treat it right away. Take command, hold the command until somebody else gets there and passes it to someone else. Let the EMT do the triage. Stay where you are, stay in place, take command.
BLS always wins. Other comments, questions? All right, thank you very much. Have a good night.